Hello, everybody. My name is Caroline Kiriga. I am a Senior Operations Consultant with Ansell Strategic. Today, I am going to be presenting on the topic of governance, specifically governance in crisis. But before I begin, I would like to thank both Ansell Strategic and Leading Age Services Australia for the opportunity to present on this topic and share our lived experience in managing a home with significant number of non-compliances in this current environment that we're in, where we're dealing with the COVID-19 pandemic. So just to begin, I was a newly appointed CEO, interim CEO, in a small standalone home near the Blue Mountains region. And at the time when I started, the home was dealing with a significant number of non-compliances following a commission audit in 2019. And also in that time, obviously, this was early this year, Australia was in the height of a COVID-19 pandemic. And most of us can agree that providers were receiving quite a lot of information, a lot of new instructions, new announcements, just an endless river of information from a lot of different agencies, and that we all had to be aware of. And we as the management team in our home, together with the board, we needed to devise our own strategy to ensure effective governance in our home, whilst navigating, no doubt, a very intensive environment. So I'll also highlight this point, that good governance recognizes that the health system is a very dynamic, adaptive collection of interrelated and interdependent components, which includes people and processes, all of us with a common purpose. And really achieving and maintaining this purpose is quite an enormous task, even for well-run, very highly functioning organizations. And for us, achieving effective governance oversight for a home that was dealing with a significant number of non-compliances in the middle of a pandemic has been quite the journey. Because unlike group aged care homes that can always draw upon expert advice and other necessary resources from within, standalone homes face that additional challenge of constantly debunking what every new state and federal health directive or recommendations may mean for the home. And in the process of doing that can often feel very overwhelming, and it did for us. So in my presentation today, I will talk about our 24-hour emergency response plan and how a small provider was able to cut through the information overload to develop a practical strategy for dealing decisively in a catastrophe. And I will also explain how we did this, or were able to attain this through our disaster simulation. So I will explain the value of disaster simulation and the applications of these very simple principles as we face a very volatile and certainly a very uncertain future in aged care. So a bit of a background about our home. I began my role as a CEO in April of this year, and at the time we were dealing with non-compliances really on all 8 standards, and governance in particular was highlighted as a problem. And as I just give a bit of a background, I'm just going to focus on some aspects of governance that we were dealing with at the time. And obviously, Australia was in the middle of a COVID-19 global pandemic, and for us, dealing with non-compliances as well as the pandemic, for us, this meant we had to be even more diligent in how we continue to maintain safe quality care for our residents. We were very cautious and we knew with the number of non-compliances that the last thing we really wanted to deal with was an outbreak in our home. We also faced another complex dynamic just in the way the building is laid out. At the time, we had two completely separate buildings, which are about 2 minutes apart. And in the past, these two buildings had always been treated as two separate homes. And so the dynamics with staffing, things like leisure and social activities, there was always a different outcome, even though both buildings were run under the same organization, the same umbrella of policies and procedures and guidelines, the same staff. It was just always different. Um, Needless to say, though, we had always enjoyed a relatively stable occupancy. The home had always had a very good reputation. We are in a very tight-knit community. And in fact, prior to the COVID-19 pandemic, the residents had always been very, very engaged with our local community. So we really wanted to understand the root cause of the issues and why things had come to this. And together with the home's administrators and advisors, we took a deep dive of the root cause of the problems that we were facing. And we soon realized that despite the good network of internal systems that the home had invested in, such as electronic recording systems, the auditing systems, which were all very contemporary, these were never really utilized to their full potential. Another problem that we faced, that we came across, was the flow and storage of information, which was very poorly understood by staff at the time. So a lot of staff sort of worked in silos. We had problems with people saving information, on the desktops rather than using a centralized system, which was available, but people just sort of tended to have their own little systems going on, and it made accessing information very difficult. For example, one time I wanted to access training records, and I found out that the person responsible for collating that information was sort of had them in their own system, even though we had a centralized sort of system of storing information. There was a lot of different systems going on within the home. The other issue we found was that there was very little, if any, analysis of clinical data. In fact, collecting data had almost become like a tick box. So it was just another tick box, another task that the staff completed at the end of the month. There was really not a lot of analysis that was conducted of any kind. There wasn't any root cause analysis. There was really never any evidence of what the data was used for, whether it highlighted any trends or whether it was used to inform continuous improvement. So we soon could see, it was very clear that we had some very contemporary systems, but unfortunately they weren't very they weren't utilized to their full potential. And what was actually interesting was we actually had staff who could sort of explain to us what the systems were meant to do, but there was never really adequate oversight. It wasn't really clear as to what was expected from them with regards to these systems. And that certainly led to the issues that we had with governance. So as explained, our home was already experiencing non-compliances at the time, and as I also briefly mentioned earlier, we've got two separate buildings, one of which has rooms, a lot of rooms and en-suites that are of a shared nature. And when we learned of the contagious nature of this virus, even with best practice, infection control processes that we were implementing. We knew that we faced a higher risk of a rapid infection spread should the virus enter our home. And this, of course, made us very, very nervous. As with many providers at the time, we had a lot of information coming from a lot of different agencies every day, and the information was changing rapidly, and it got to a point where there was information overload. Certainly it felt like that for us, and it was very easy to miss some critical guidelines. And this made us, nervous and even more cautious of the information and how that information flowed down to the staff. We certainly wanted to make sure that they were getting the right information that pertaining to best practice with regards to COVID. Our rosters were also greatly impacted because of the high number of sick leave. Certainly, we never really took anything to chance. We asked our staff not to come in if they or their children were experiencing any symptoms, even mild. And being located in a regional area, finding replacement staff is not always easy, till today. We had we also faced some issues with some testing centers. We experienced significant delays with test results. Sometimes our staff had to wait for more than 72 hours, which also before they could get their test results. And this obviously impacted on our rosters greatly. One of the local testing centers, would advise staff that they don't really hand out test results after 4 p.m. We had some issues. We had tried to make arrangements with them to at least prioritize our staff test results. But this was not always the case for us. And needless to say, we as an organization felt very isolated in that time. So as an organization, we knew we had to be very diligent in our approach in managing the non-compliances that existed in the time, and the risk of COVID-19. And we very much understood that as a standalone home, unlike group homes, we did not really have the advantage of relying on other staff or another manager if one of the managers was unwell, or with other shared staff, or even extra resources such as PPE from another home should anything happen to us. And so because of this, we had to adopt a very risk-averse approach, which we continue to do so till today. Even with the number of COVID-19 incidences winding down at present, we continue to operate as though the virus is still very present in the community. And so our success in this area very much relied on taking our staff on this journey with us. We know effective governance is not only a management concept or a leadership concept, and therefore we decided to take a whole of organization approach. And for us, staff training became very, very key as a very practical approach from everybody, including some of the board members who were very interested. So following on from this, we decided to adopt a very practical approach of a disaster simulation on the management of COVID-19 in our home. Our approach was to involve everybody, the senior leadership team, our clinical staff, non-clinical staff, our hospitality admin, everyone. And we really went through a step-by-step hypothetical, scenarios that the staff were likely to face. For example, a staff member who had worked the previous morning shift rings up to say that she was experiencing COVID-19 symptoms and had just been tested and confirmed positive. Or on a Saturday afternoon, the RN receives a phone call from pathology confirming the resident's COVID-19 results were positive. And we really wanted to observe the staff's approach and how they would react in these situations. And if the instructions and all the guidelines that we had given them, all the training that we had implemented in the home, you know, we wanted to know if this actually made sense to them. We really wanted to see from their approach how they would react in that instance. And for us, our first simulation really did not go as expected. It opened our eyes to a lot. For example, we realized that we had given the staff so much information. We had created so many resource folders for them. And in that instance, finding information for them was not always clear. So after the simulation, we sat down and we had a very open, transparent conversations about our processes, and we gave the staff an opportunity to ask questions and clarify any misinformation on their part. We discussed the role of every individual when it comes to infection control, and the need for the staff to continue holding each other accountable when they sort of saw the staff or anyone else not doing the right thing. So we took those learnings and discussed them at staff meetings as well as leadership meetings to gauge how we could better improve. So as discussed, the learnings are very eye-opening for us. We knew that we had to go back and really rethink our strategy. We were still, experiencing quite a bit of information, that was coming to us, and at the time, our management team and the board, we needed to devise our own strategy to ensure effective governance while navigating this very intensive environment. So we began by really simplifying our COVID-19 response plans to ensure that our staff on the floor had relevant, up-to-date information that was easy to understand and that gave them the confidence that they knew exactly what they needed to do in the very first few minutes or in the very first few hours of a confirmation of a positive case. The staff were very honest in their feedback about the resources, the resource information that was available to them. We learned that the resource folders, whilst effective for us, they were not always beneficial for the staff. Sometimes that information was too bulky and too overwhelming in that instance. But we also had some very positive feedback from the staff with regards to really how they felt. After they went through the simulations, a lot of the staff gave feedback that they fully understood, they were confident with what they were dealing with, we had staff put their hand up to say that they would be confident in coming in the event of an outbreak in our organization, and that the practical disaster simulations gave them that confidence to deal with very tricky situations that they had only imagined of before. So we also talked through some of the practical, task delegations that the RNs could do in terms of how they would best utilize the staff to do various other duties whilst they were on the phone to a distressed family member, for example. We talked about communication and the flow of information to family members and other stakeholders in the instance, or as soon as a positive case was confirmed. And all these steps were in our 24-hour guideline response to a pandemic, but it was certainly very interesting for us to put it in a practical perspectives and really review our gaps that we were experiencing at the time. One of our biggest risks, again, was with one of our buildings, which has share rooms and en suites, and the staff were able to ask, more questions of what more they could do from an infection control perspective when it comes to this particular building. So we learned a lot, certainly, from those simulations, and from those learnings, we're able to go back and review our response plans to ensure that we had the right information for staff. So what other aspects of governance did we learn from these disaster simulations? As I said, taking the staff on a journey with us helped them really understand their part in managing non-compliances within complexities of a COVID-19 pandemic. The simulations helped the clinical leadership team to have a much broader perspective on effective management of safe quality care for our residents. Having that big picture rather than being just task focused, help them understand how their decisions affected the different stakeholders within our organization. And that leadership approach was very key in them being able to understand how each piece of the puzzle sort of fits within the organization, and how those very small and big decisions affected everybody. The staff were also able to see how we partnered with our consumers to provide safe quality care, and we actually received feedback from residents and family members that they felt more comfortable and comforted that the home was taking steps to ensure safe care as much as possible. We had residents, the residents could see how everybody was involved in these simulations, and that in turn resulted in improved relationships and trust between the residents, the families, and the staff. One of the examples I can also give, we in our home actually implemented the wearing of masks very early on, and this approach was actually well received by our residents, and again resulted in that deeper trust, and the residents were comfortable that whatever we were doing it to try and maintain that safe quality care. So for us as a management team, how could we also tell that what we were doing was actually effective? And that's the key part of these disaster simulations. What was the training practical enough, and was it effective? Were the guidelines sound and clear, or were we giving the staff so much information that they couldn't cope? Which was a good way to evaluate how we were performing in that time. We looked at other clinical indicators as well, such as our infection rates, at the falls, and sort of how that also fitted in the governance piece. And for us, looking at governance, this approach brought a greater awareness for staff who were able to join the dots, between best practice and consumer engagement, and that leadership approach. And just to conclude, I just want to highlight that good governance recognizes that health systems are a dynamic, adaptive collection of interrelated and interdependent components, including people and processes, all of us with a common purpose. And really achieving and maintaining this purpose is quite an enormous task for any given organization, and certainly for us, achieving effective governance oversight for a home dealing with a significant number of non-compliances in the middle of a COVID-19 pandemic has not been easy. It has been quite the journey for us. We recognize that disaster simulations are only one component of how we continue to achieve effective governance, and there's certainly much more to effective governance. However, for us, this has been one of those key concepts that has and continues to help us understand, how we are tracking and fully understand our position, and how well we are going, in this very intensive environment. We certainly know that there is much more to effective governance, but just again to highlight, this has been our experience in fully understanding, how we can evaluate that we're doing the right thing. Our disaster simulations have played a very key role. And that is it from me. Thank you very much.